Yes, I think EQIP was in a period of transition at the time. I think, well, I guess all organisations are always in a period of transition, but I think it's probably fair to say that after many years of Richard Grohl's amazing leadership, he was a phenomenal leader in establishing EQIP and bringing people together and generating ideas and resources to allow us to do work collaboratively. I think it's probably fair to say that when Richard stepped back, we spent a little bit of time deciding what we wanted EQIP to look like. And my commitment when I was president, I guess, was in a number of areas. First of all, to continue Richard's commitment to making sure that we were an improvement body that was evidence-based. So trying to bring real rigor to improvement activity, very committed to that. I was very committed to ensuring that as an organisation, we continue to learn from each other with very diverse set of countries represented, very diverse set of national leads from each country. But what we had in common was a passion for general practice and a passion to improve general practice. And I really wanted to make sure that everybody felt that they were part of this broader initiative. So that was the second thing that I was very keen on. And then the third thing was I thought that whilst meeting twice a year in exotic locations around Europe was a wonderful sociable thing to do, what I really wanted to do is to make sure that we actually delivered work that non-members of EQIP would notice. And for that reason, I was very keen on making sure that we did big international projects, comparative projects together, and that where possible, we had resources to allow us to do those projects properly rather than being done on a shoestring, which is the usual way that we operate. So those were my ambitions, but I had a very limited period of time to deliver those ambitions, I must say. Actually, I mean, going back to your original question about what were the big issues that were happening when I was president, one of the big issues is we were dealing with the consequences of a significant commitment to evidence-based medicine. And that was quite at that time, quite a biomedical approach towards medicine, a disease-based approach towards medicine, which was right. There's a lot of evidence out there. We want to use quality improvement methods to try to improve quality. But I think probably that we became over preoccupied with the medical causes of ill health, particularly for us in general practice and in primary care, where a lot of the ill health that we see is a consequence of social problems, housing, employment, lifestyle factors, a whole range of issues like that. And therefore, it's appropriate that we use social interventions like social prescribing, whether it be exercise or cooking on prescription, or dance on prescription, or a whole range of other interventions. I think that's really exciting. And I think we're now getting to the stage where all members of the primary care team, but particularly doctors, are very aware of where the medical model, the disease-based biomedical model of health adds value, but also much more sensitive to where it doesn't add value, and indeed where it could even be damaging, the overdiagnosis, overtreatment agenda, for example. And where it doesn't add value, that's where, rather than saying, well, it's not our job as GPs, holistic doctors, what we say is actually there are ways that we can intervene at a social level in order to address the social determinants of health problems. It's complex, it's difficult, it's not necessarily something that we're trained to do, but we're learning about it and utilising it. And I think that GPs, more than any medical specialty, are very much in the forefront of thinking about that, because we're exposed to the consequences of social problems.